Okay. All right. So let's finish up today. Try to finish up chapter 10, talking about the CBC in general and the parts of the CBC that we need to know. Okay. WBC differential. Okay. You guys are already doing this. This is talking about the automated or the manual differential. So what a differential is we look at 100 white blood cells and we differentiate what they are. So the 5 we look for, of course, normal ones, neutrophils, basophils, eos, monos, and lymphocytes. Okay. Now those are normal. That's the 5 we have. Before we finish hematology, though, you're going to be able to recognize all the abnormal stuff. Okay. You're going to know exactly what they are, or at least know that they're abnormal. Okay. By that time, but my goal, and I will teach you what they are and what they look like, and you'll be responsible for knowing what they look like. Okay, all those things that are in the bone marrow normally sometimes get out into the peripheral blood when you have abnormalities. So you got to be able to interpret those cells and know what they are. Okay. We did talk about Romanowski stain. I told you Romanowski stains are kind of like a bag of Skittles, and we use Wright stain as like the green Skittles or the yellow Skittles, whatever. Okay, so Wright stain is the stain that we use in hematology all the time. I told you that a lot of stains now a lot of Wright stains are actually a combination of stains. It's Wright stains and Giemsa stain. You may see that on your box or your carton when you get into the hospital. The Giemsa stain is actually a parasitology stain. It is used for malaria. Okay, so malaria 9 times out of 10 is diagnosed on just a routine CBC. The patient comes in the ER with a high fever, not kind of fatigued, not feeling good, usually have hepatomegaly, which means enlarged liver, and then they do a CBC on them. And then during the CBC, of course, the patient's going to be anemic, so you have to do a morphology on it. And so during the morphology, most of the time the tech will see or indicate that there is malaria parasites in the red cells. Okay. So Giemsa stain's also part of it, but Wright stain is what we just normally think of as hematology stain. Okay. All right. So we interpret increase and decrease in the cell types, and then I talked about absolute concentration a little bit on Monday. Okay. Very important to know the absolute values. Okay. All right. So let's talk about peripheral blood smears in general. So you guys have already looked at some smears, but let's talk about how we make them and these kind of things as we go. So blood smears are reviewed for overall blood cell morphology. Okay. Now, we normally, when I use the word morphology, we're talking about red cells. Okay. But WBC morphology also helps us to determine what those cells are. When I gave you that little flow chart that had the key. Let me see. Here it is. Candace, I told you the other day there's one up here. You're welcome. It's probably not as good as the one that you got, but from when you were here before. But I made that one up just real quick the other day. Okay. So even though we look at white blood cells as the granules and that kind of thing, that is essentially their morphology, how they look, what they look like. So we use that for all of the things for the blood smear. So smears prepared and stained, examined macroscopically and microscopically. Okay, so macroscopically is the shape of it to make sure we don't have a bunch of air holes, those kind of things, and for the color of it. They're going to look a certain way. All right. Well, no, we're not going to talk about that. Okay. Values correlate with the parameters reported by your instrument. Okay, so this is the reason why I like hematology. I am a hematologist. That's what I would rather do at the hospital every time when I work at the hospital. I would rather work in hematology. I'd rather do urinalysis. Shit, I'd rather do blood bank and micro than I would clinical chemistry. I hate chemistry, to be honest with you. Okay, I can do it. I understand it. I teach it. I know the theory behind it all. But it's hard for me because I'm a hands-on guy, okay? In chemistry, if you have 120 sodium level, I can't fix that. I can't verify that except to rerun it on the same machine I just run it on, okay? 120 would be critical. It'd be really, really low, okay? If you have a 6 potassium, all right, all I have to do is I have to put my faith and trust that my machine's working properly. You know what I'm saying? But if you have a 100,000 white blood cell count, my machine gives me a 100,000 white blood cell count, I can take a drop of your blood, put it on a slide, stain it, and then I can look at those cells. And I can say, yep, that's 100,000. You know what I mean? Just by the sure visibility of the cells, okay? That's what I like. I like to be able to verify things. And that's essentially what we're doing when we do a morphology. The machine is going to give us the parameters, okay? It's going to give us the counts. It's going to calculate the indices for us, okay? Whatever those tell us, I better see on the slide, all right? That's the reason MCV is so important. That's the reason MCHC is so important. If it gives me an MCV of 120, and then I do a blood smear, and all the cells are normal, something's wrong. Does that make sense? Okay? But in chemistry, unfortunately, we can't do that, okay? But all the other departments, we really can. We can look at it and see something that's visual, okay, as we go, okay? All right, so peripheral bloods are very, very important for us. All right, so we should always use a low power magnification to quickly scan and assess the general appearance of the cells. All right, so there is a rare, all right, like 1 in a billion chance that a patient can have a megakaryocytic leukemia, okay? If they have this, then they actually put megakaryocytes out of the bone marrow. They produce too many megakaryocytes. Now, before you ever look at the slide, you're going to have over 1 million, 2 million, 3 million platelet count, okay? Which is, you know, way, way high, because what's a normal platelet count? 150,000 to 450,000. That's exactly right. 150 to 450 is what your machine's going to put out. Just remember that's 1,000, okay? But yeah, and they may have a 2 million platelet count. So you definitely know you got a problem because you got all those platelets, okay? So then on low power, you would scan to see if you see large megakaryocytes on the slide, and you would definitely recognize them because they're huge, okay? And matter of fact, I will show you some megakaryocytes on the bone marrow from an actual bone marrow aspiration later on, okay? All right, so looking at the distribution on low power is important to us, okay? High concentration WBCs at the feathered edge indicates poor cell distribution. So it means your slide's not doing, you didn't make your slide like you should have, okay? Essentially what that means. And then, of course, those large abnormal WBCs push to the outer edge of the smear. So what it's saying is we want to do our counts at the, basically at the feathered edge, like we should always, okay? So we have our slide, like we have looked at multiple times now, and we should have blood kind of distributed in this pattern, okay? So when on low, we want to look in this area that we're going to probably count and make sure we've got good distribution of those white cells, okay? But because we're going to take a drop of blood and we're going to use a slide to make that blood spread across and then push it out to get our feathered edge. That's how we make a slide, okay? Large cells that are abnormal, things like blast or even those megakaryocytes, if they're there, are going to be 10 because they're so heavy to be pushed toward the edges. So it does us good to, when we're putting the slide under the scope to get it in focus, go ahead and look at it under low and scan the edges of the slide. And if there's anything abnormal, even though you may not realize what it is, when you see, you're looking at it and you got all these little bitty dots that you can't really make any judgment about, and then all of a sudden you got that under the scope, you're going to say, hey, that's abnormal. And then you're going to go in and zoom in and look and see what it is. Okay? Does that make sense? Yeah.
When do you know when you're supposed to make a blood smear?
The machine will tell you. Okay? Every hospital, every machine has to have parameters put into it. Okay? So in other words, it has to have acceptable normal ranges put into the machine. Okay? So like we talked about the other day, those scatter plots.
Yeah.
All right? But over here in this area, there really shouldn't be anything, right? Okay, but then all of a sudden it gets a little population of cells, and the machine says, I really don't know what that is, but based off of its size and shape, it's going to be abnormal blast. Okay, because remember, blast, they're immature cells. What do we talk about maturity of cells? What do? They go from large to small, right? And so it knows that size-wise, based off a number, all normal cells should fall in this category right here. Every one of them. It doesn't matter if it's lymphocyte, monocyte, EO, basocyte, whatever. They should all fall in that size. So when you get a big population over here, it says, hey, not real sure what it is, but that's definitely abnormal of cells. Does that make sense? And so based off of the parameter size, it'll give you a flag and it'll say, hey, you need to look at this. This is abnormal blast or abnormal something is going on. Okay? And that's how these machines work. Okay? So this would be like your WBC. And there's actually some scatter plots for RBCs too. And you can look at that chapter 39 and look about it. We'll talk a little bit about it at the end. But red cell, we talked about how that, you know, you should have kind of a distribution like that, you know. Actually, it should be more like this, you know, because you're always going to have some fragments. Because remember, it's going to pull in billions of cells out of that one sample, you know, and look at them. But it says, okay, this is 80 to 100 femtoliters, okay. So it says all my population should stay right there. That's where the majority of my cells should be, okay? But if I get this weird shift and I get a big hump there, that tells me there's a population of cells that are, you know, 120 femtoliters from 100 to 120. So what it's going to do, it's going to flag and it's going to say macrocytes present, okay? And so it's going to say you need to do a morphology on it. In other words, you need to verify what I'm seeing as the machine based off the size. Does that make sense? Okay. So that's how it works. Your machines are set to have certain flags. Okay. Now, your individual hospital can adjust those flags, the size and that kind of stuff, based off of what? Huh?
I don't know.
No, that's it. You just didn't set down the.
Reference ranges.
Huh?
Reference range.
Reference ranges for who?
A population.
That a girl. Your population. Because things like we were talking about before, and I know we always use this, but this is the best example. People who live in Denver may have a little bit larger cells than people who live at the beach, just because of needing that extra hemoglobin. So their cells may be larger. So they're probably not going to be above 100, but it may be like 95 to 100 is their normal cell population. So anything below that, it may flag you need to look at their cells if they fall into the 80 category, because they're small for that particular population. Does that make sense? So you can kind of change that kind of thing. So a lot of machines, or a lot of places too, they have actually fixed their instruments so that they don't print you a printout of the results unless there's an abnormality. And then it'll print you a sheet. And then if you get a sheet, you know you need to look at it and say, I need to do a DIF or a morphology. Okay? That makes sense. That's kind of crazy, but that's absolutely true. A lot of people do that. Okay? All right. Also, you'll see smudge cells, ruptured cells called smudge cells. You guys got to experience this yesterday in the lab with the cell-o-vision. I hated that they put them in there. But sometimes you see them on just a normal individual because of just the violence. I know that sounds crazy, But the violence of making a slide is, it is a violent process to those cells. And so they can be busted or destroyed. So you need to look and make sure there's not a bunch of them on there, okay? Because if there's tons of them, that means that there's a problem. That patient's protein may not be good enough or that kind of thing, and that may be leading to some other abnormality, like a leukemia or these kind of things, all right? Okay, questions about that? So I put this little chart in here, and it's a good little chart. It kind of tells you what you do on 10, what you do on 40, and what you do on 100. And you should actually do that. I know at my experience and that kind of stuff as a tech, a lot of times I just go straight to the 50 or the 100, whatever I'm going to do. And I think I mentioned this already, but in the hospital, when you guys start working in the hospital, you're going to find out that I make you do diffs on 100, okay? But most hospitals have a 50X, which is also an oil. And all it does is it basically drops the field of view, so you're getting a bigger area. You can still see good enough to call the white cells and that kind of stuff. You just can see more white cells in a field to help you get done with your diffs quicker, okay? But morphologies should always be done on 100, no matter what. You should always do your morphology of the red cells and platelets on 100, okay? But these are not in there, but I'm just telling you, when you get to the hospital, you're going to see that there actually is a 50X on the microscopes, okay? But it is oil, and you can see the details and that kind of stuff of those white cells. Yes?
Did you say morphologies and diffs on 100?
I said I make you guys do diffs and morphologies on 100, but diffs can be done on 50X when you get in the hospital, but morphology should always be done on 100, no matter what, okay? All right, so it talks about that lower magnification. One of the big things is looking for like stacking or aggregation. Stacking of the coins is a term called rouleau. Many of you guys are LSU. Anybody LSU fans? Please say no. Rouleau, R-O-L-U. What is it? E-A-X. Is that how they do all theirs in, is that what it is? Is it U-E-A-X?
Close enough.
No.
No, that's not spelled exactly right. How does it spell?
E-A-U.
E-A-U. Okay. X. Okay. All right. I knew it was something, but it's like fridge, you know, with all of the stuff. But it's called rouleau. This is something you guys need to know. Rouleau is stacking of coins. The RBCs basically kind of stack up like coins, and you'll see these. Ms. Cole will also talk about rouleau in blood bank. Patients that have rouleau can give you false positives and make it look like they're having agglutination, and it's really rouleau, okay? We'll go ahead and give you a disease. It's called multiple myeloma. All right. Multiple myeloma is the same thing as plasma cell leukemia. Okay. So if it's plasma cell leukemia, they have an increase in plasma cells. What does say plasma cells turn into? Antibodies. And what did I tell you antibodies classification is? So like carbohydrate, lipid, protein, nucleic acid. What is antibodies? What is immunoglobulins? Proteins. That's exactly right. So they're proteins. So patients that have multiple myeloma, due to having so many antibodies in their system because of those abnormal plasma cells, they have an increase in protein. So what's happening is the protein is causing these cells to be adhesive, and they kind of stick together in like coins. Okay. So what we do in blood bank, we don't do it in hematology because it doesn't really matter to us. But in blood bank, you do what's called a saline replacement. So like you add your reagents, do everything else, and if it's true agglutination, you add saline and kind of wash it a little bit, and then respin it. And if it's true agglutination, it won't go away. But if you wash it with saline, it'll wash those proteins away, and then those cells will free up. And so Ms. Cole will teach you about that in blood bank next fall, or this coming fall. Okay. All right, so cold agglutinins are one of the things that we worry about. Anybody ever heard, well, I know you have heard, if you hadn't, you will soon. Ms. Cole teach you guys about mycoplasma, bacteria, mycoplasma. Okay, so you got another, yeah, that's right, y'all are doing anaerobes right now. Okay, so the next section is going to talk to you guys about an organism known as mycoplasma. Mycoplasma pneumoniae is the actual organism that we concentrate on. There's actually other mycoplasmas, but it's the big one that we are concerned with. Causes atypical walking pneumonia is one of the diseases that it has. Well, getting this bacteria causes an immune response to our body. So when our temperature, body temperature drops, it causes these proteins, these immunoglobulins that are IgM to attach to our red cells, okay? So then it makes those red cells stick together. So then when they go through the impedance, the machine reads them as being huge cells. And so you get an MCV of like 150, 160, okay? But then when you look at the slide, it's because those cells are all stuck together. And also your cell counts are lower because you got 4 cells being counted as 1. Does that make sense? And so cold agglutinin is a big deal. So we usually just like incubate the blood at 37 degrees for a little while and then run it through, and we can usually get a normal count. Okay. All right. So this is what rouleau looks like. I mean, this is what a cold agglutinin looks like. So you can see that's 1, 2, 3, 4 cells, but the machine counted it as 1 cell because they're so stuck together. It just figured it was 1 cell. So now I give you a really, really high MCV. Same way with these. These are 2 cells. These are 2 cells, but it counted them as 1. And so it looks like your cell count is low, but really it's because all those cells are stuck together. Okay? So that's an important thing about looking at low power. And then here's the term rouleau. Good, thank you. I thought it was in there, but I wasn't sure if it's there. So this is what rouleau looks like, the word rouleau. So be familiar with it. Stacks of coins, and like we said, it's multiple myeloma. It's, this disorder is associated with multiple myeloma. Okay. This is what rouleau looks like. It looks like stacks of coins. You can see they're kind of stacked on top of each other. Okay. Now listen. Now, when we look at these pictures, all right, in your brain, you need to always think I'm in the feathered edge, okay? Because that's where we do all of our counts at, is in the feathered edge. So when I show you abnormalities, always think that the cells should be apart, not touching each other, those kind of things. In a good counting area. Remember that very first day of lab, I kind of talked about a good counting area, okay? Because every one of you, and I know you've done it because that's what techs do that don't know yet, you have counted into the deeper part, right? And your cells got really tiny, and you're like, oh, hell, I don't know if that's an EO or a neutrophil or, you know, whatever, because their colors are not exactly right, because it gets thick, right? You think about it tomorrow in lab, pull out one of those slides and go to that little deeper edge. It looks like you got rouleau all over the place, but that's not what it is. That's just because it's thick in that area. Rouleau and those kind of abnormalities, we have to always think about in that feathered edge, where those cells should be spread out, but they're not, okay? So always make sure you remember that. If you get too deep, you need to get back out to the thing, okay? Another thing on low power magnification that you can find, I mentioned this yesterday, Monday in class, platelet clumps and platelet satellitism. This is what I was talking about earlier. Platelet satellitism is a really weird phenomenon. It usually occurs in EDTA tubes, but it can actually be eliminated by using sodium citrate, which is the blue top tubes, okay? And essentially what it is, those platelets, the EDTA kind of makes the platelets sticky, and they're attracted to the neutrophils. And so you'll see platelets surrounding neutrophils. So they're satelliting around the neutrophils. So they get attached to those neutrophils. Then when you run it through the machine, that's happening. So what's going to happen to your platelet count? It's going to be decreased. That's exactly right, because they're stuck to those neutrophils. So they're riding in with the neutrophils instead of going into for the platelet count.
Could you repeat this, the ETA, what sticks to the neutrophil?
Platelets.
But
Yeah, and that's what causes platelet satellitism. Okay, and you can eliminate that using a blue top tube. Okay. All right, and then this is a picture of platelet satellitism. See how the platelets are around the edges of those neutrophils? Okay. And that would be platelet satellitism. It's kind of platelet clumping too, but see how they're kind of adhering to the edges of those neutrophils? Okay. What?
what kind of microscope does one like that?
That's just the stain, really, that's making them a little darker. Yeah, it's mostly the stain. This is a right Giemsa stain. You see the right Giemsa? So the Giemsa may make it a little bit darker on it. And then, of course, this is 100X. You're looking up really quick.
Are platelets that small?
Yes, platelets should be this small. That's the reason, like in your cell division lab yesterday, that was considered a giants. Those were giant platelets because they were about the size of a red cell, you know. But no, this is a normal size for a platelet. This is what platelets should look like normally. Okay, very small. All right, questions about any of that, guys? Okay. All right. So this is a good blood smear, normocytic, normochromic erythrocytes. You can see they're kind of good. You got kind of a few little, I wouldn't really call them burr cells, but a lot of times students do call these burr cells. But to me, this is just an artifact of the slide making because it's like 2 per 100 cells, you know. So to me, that's not really enough to call it anything. But look at the size of the cells, their shape, their central pallor, the color's good. So these are normocytes, normocytic, normochromic, just like a normal cell should be. Notice how they're not really overlapping each other. Got a little touching there, but that's still not bad, okay? And you don't have big open spots. That's another thing that students have trouble with sometimes. They don't want them to be overlapping, so they'll go out really, really close to the edge of the feather, and then they've got big gaps of the cells. So you want them to touch, or not touch, but you also don't want them to be, 4 inches apart, okay? So very, very good counting area there, okay? All right. Now, I made mention of this when we were talking about just lymphocytes in general, okay? But lymphocytes help us on morphologies also. Even though we're looking at them on the diff as lymphocytes and counting them, they help us on our morphology. Red blood cells, normocytic red cells, should be about the size of the nucleus of a lymphocyte, okay? So that lymphocyte, I could lay a red cell right on top of it and it would cover up that lymphocyte or the nucleus of that lymphocyte, okay? It's a very important tool in helping you judge the size of red cells, okay? And I suggest that. You can scroll around somewhere till you find a good field, and most of the time you're going to find a lymphocyte in it, okay? Find one with a lymphocyte in it, and then that way you can kind of judge the size of your red cells based off of that, all right? That makes sense? Okay. High power, you guys are already doing this for 100 cell classified diffs, also looking at platelet estimates. I haven't made you do a platelet estimate, but we will. I'll make you do one a little bit later on. And essentially all you're going to do is you're going to look at a field, count the platelets, do another field, count the platelets, do another field, count the platelets, that kind of thing. And then there's a little calculation that you can do. And that should be within about 5% of what your machine gives you, okay? And so you can do WBC estimates also the same kind of way as we go. All right, we'll talk about those a little bit later on. All right. So RBC morphology should always be done on the high power magnification, the 100X. We're looking at size, shape, color, any inclusions. We hadn't talked about that yet, but we will. And then you always need to compare it to your instrument report. So look at the MCV, MCHC, those kind of things. RDW, and make sure that your machine is telling you what you need to know. All right, any questions so far? All right, So the next one's going to be a bunch of pictures and stuff, okay? So we're going to talk about RBC morphology, erythrocyte morphology in the next few chapters, or next few slides, okay? All right, so what is an erythrocyte, okay? You need to know a normal erythrocyte is also called a discocyte, okay? Due to the biconcave shape, it's known as a discocyte, not like disco ball or disco 70s, but disc that you used to throw, okay? A discus is what we call it a lot of times. So they're called a discocyte, all right? Is another term for them. The size is about 7 to 8 micrometers, and then their volume, so size of them, volume-wise, is 80 to 100 femtoliters. It's a normal RBC. Okay. Central area of the pallor, surrounded by a rim of pink staining hemoglobin. Pallor is caused by that closeness of the two biconcave shapes that we talked about before. Occupies about 1/3 of the diameter. So anything above 1/3 of it, we would consider it hypochromic. Okay, when you use the term hypochromic, and the MCHC ought to justify that. Okay, all right. So let's talk about anesiocytosis. This is the first one. Okay, so I told you guys there were two terms: anesiocytosis and poikilocytosis, or poikilo, ever how you want to say it. Doesn't matter to me. I call it poikilo, and here's why. Anesiocytosis deals with the size of the cells. Poikilo deals with the shapes of the cells. Okay? And I always remember, because pigs, want to be in shape. So you'll never forget it now. Anesio is the size, poikilo is the shape of the cells, okay? So if I have cells that are microcytic, macrocytic, normocytic, all that, I have anesiocytosis, okay? If I have red cells that have burr cells, helmet cells, teardrops, those kind of things, sickle cells, whatever, then I have an increase in poikilocytosis, okay? And a lot of times they're actually called poikilocytes if they're not normally normocytes. They refer to it. I'm fixing to put it up there. Just hang on a second. Okay. I know I'm getting ahead of myself, but trust me. Okay. So macrocytes. Remember, macrocytes help us to, we use the MCV, so greater than 100. Microcytes, less than 80. Okay. And that's what we're looking for. Okay, so this is what anesiocytosis would look like. So if you were looking at a smear, okay, you've got cells that are just normal, like they're supposed to be, but then you've got normal cell, then you've got a macrocyte, look how big these guys are, and then you've got a bunch of little bitty spherocytes and microcytes. Okay, so you see that there's a difference in size. Shape's pretty about the same. Their shape's good, it's round like it's supposed to, with the exception of the spherocyte, of course, who is a sphere shape. But all the rest of them have a little central pallor, you know, they're just bigger, okay? So shape is normal right there, okay? But size is not. So then we would say anesiocytosis, okay? And I would say probably 2+ anesiocytosis on that, because you've got lots of different ones in that field. Okay. All right. Questions about anesiocytosis? Any questions? Okay. All right. So anesiocytosis, how do we tell off of the CBC? You look at the RDW. RDW above 14.5% is going to indicate that you have some anesiocytosis. Okay. So we don't normally just look at the MCV, okay? We look at the MCV to give us whether we should see macrocytes or microcytes, or normocytes, but anesiocytosis is the RDW. We look at the RDW, okay, for it, all right? This is what normocytic should look like. So this kind of shows you the difference in that and that. Okay, so definitely anesio, and these are normal. Okay, see the difference? Lots of different sizes. Everything's uniform. Okay? All right? So we know what microcytes are. We've talked about them. We look at them most of the time. Okay? Not all the time. But a lot of the times, if you have microcytes, you're also going to have hypochromia. And the reason it is because iron deficiency anemia is the most common cause of microcytes being present. Okay? If you have iron deficiency anemia, not only are you going to have small cells, but you're also not going to have hemoglobin. Okay? Because of the iron. We don't have enough iron to make hemoglobin. Okay? So you're going to see washed out cells. All right? But they can be normochromic. So don't think that you can't. And then remember, spherocytes are usually small, microcytic, but they're full of hemoglobin. Okay? So they're hyperchromic. All right? So you can see here, this is a classic blood picture of iron deficiency. You can see the microcytes here. This cell right here, we'll talk about that one in just a minute. It's unique. See that cell? That's known as basophilic stippling. That is a dead cell. That cell has died. Okay? And we'll talk about it later on. But if I take these cells, this cell, this cell, this cell, this cell, this one and this one, that one, that one, and that one, and I put them over on top of that nucleus, they're going to be a lot smaller. Okay?
You said this was anemia?
Huh?
You said that was anemia?
Yeah, this is what iron deficiency looks like. And a lot of times the cells will be even washed out more than that. It'll typically look like that cell, these cells right here, this one, and that one, you know. The central pallor is a lot larger, you know. So that makes up more than greater than third of the cell, okay? Macrocytes. So macrocytes are large red cells. MCVs are greater than 100, okay? The most common time that you're going to see macrocytes are going to be in like vitamin B12, folate deficiency, pernicious anemia, those kind of things, okay? People who are alcoholics, chronic alcoholism, they tend to have macrocytes in their blood. We'll talk about that later on, but they do, okay? What's unique about macrocytes is a lot of times macrocytes have normal MCHCs. In other words, so they're normal color, just like a red cell should be. They're just large, really, really big, okay? All right, you always have to remember, though, that reticulocytes are polychromatophilic, so they're blue, but they're always large, okay? So in other words, if you have anemia, you're probably going to have an increase in reticulocyte count. So you may see some macrocytes even on a iron deficiency person who normally has most of their cells as microcytes, okay? And this would be a good picture of macrocytes. And so you can say, oh, that cell's bigger than the whole lymphocyte. So is this one. Okay? And remember, we're talking about the nucleus of the lymphocyte, not the whole cell. Okay? But these cells, these red cells are so large, they would cover up the entire lymphocyte. Okay? So that's a good indicator that you have macrocytes. All right? Questions about any of that, guys? All right, so let's talk about poikilocytosis, okay? So like I said, I was taught it's called poikilo, but I've also seen it called poikilo, okay? So every how you want to say it, it's perfectly fine with me as long as you know what it means, okay? So poikilocytosis is used to describe non-specific variations in shape, okay? Cells like a teardrop cell, okay? Sometimes sickle cells. These cells are known as poikilocytes, okay? They'll just call them poikilocytes instead of calling them what their name is, all right? So be aware of that sometimes, okay? Anytime you see poikilo, it's talking about shape of the cell, all right? So we're going to look at some of these shapes of the cells and kind of get good names for them, all right? So this would be poikilo with acanthocytes, spherocytes, echinocytes, helmet cells. There's just lots of different things in this one particular slide, okay? Also, you see microcytes and macrocytes. So you would actually, when you did the morphology, you would note that you have an increase in poikilocytosis and anissiocytosis on these patients, okay? Questions? All right. This is a good helmet cell. That one right there. You see that one? How do we get helmet cells?
The macrophage bites it and it doesn't.
What's it taking out most of the time? You remember?
No.
It can be the nucleus sometimes, so if it gets the Howell-Jolly body out. But usually it's what? G6PD deficiency. I like it on my steak.
What? You should have put nothing on the
Right.
plate.
But I like this on my steak.
Butter?
Heinz 57.
Heinz body.
Heinz bodies.
Can
Yeah.
you, I don't remember what Heinz bodies are.
They're precipitated hemoglobin. So like oxidized precipitated hemoglobin. Okay. And it is caused by G6PD deficiency. G6PD deficiency is part of that hexo-monophosphate shunt of the glycolysis method that we use. Okay. All right. So we're going to show you pictures of them. And then I think I've got like real pictures. Okay. So acanthocytes. So that little chart is in your book. You can go ahead and look at it if you want to. Acanthocytes basically are also known as spur cells. They're basically irregular shaped little cells. They almost look like kind of like fragments of cells, but we don't call them fragments because we actually have a term for when it's a true fragment. Okay. Remember acanthocytes, it's usually a lipid problem in the membrane. Remember us talking about that? Lipid, the cholesterol phospholipid ratio is off. So we get what's called acanthocytes. Okay, so increased free cholesterol accumulation. All right. Acanthocytes is basically just little like this. They're usually kind of like that. That would be like an acanthocyte. I thought I had a picture of an acanthocyte. There's all kind of pictures in your book. So, you know, even if I don't show you one. Hey, while I'm looking at this, let me call your attention to your book because the PowerPoint didn't talk about it, but I will talk about it later on. But on page 163 of your book, I know if you don't have your book, listen, jot down 163. Table 10.7, okay? There are some things that you will see as inclusions or cytoplasmic abnormalities in neutrophils, okay? You need to know what Dolly bodies are, okay? The very first picture is a Dolly body. It's essentially like a little blue area inside the cytoplasm. I think Dolly bodies are like remnants of the endoplasmic reticulum. Y'all remember that from biology, the cell structures, the ER, endoplasmic reticulum, okay? You see these in May-Hegland anomaly and also in infections. That's the big thing, infections. Bacterial infections, you see an increase in Dolly bodies. D-O-H-L-E is how you spell Dolly. And it's on page 163, table 10.7. Okay? Make sure that you're aware of that thing. Toxic granulation is when the granules in a neutrophil start turning kind of blue. And they get a lot darker and a lot more of them than what you normally think about. Toxic granulation is a product of severe infection, bacterial or fungal infection. Okay? So in other words, it's like they're reactive. Those neutrophils have become reactive and they're doing what they're supposed to do. Okay? Vacuoles. Now we know we talked about vacuoles and monocytes. But in neutrophils, you also can have vacuoles, and that's another indicator that there is a bacterial infection. Okay? And then you can see things that are engulfed in the white blood cells, in the neutrophils, okay? Where you see phagocytosis has occurred. It can be yeast, it can be bacteria, actually it can be anything, but that's the two big common ones that you see, yeast and bacteria. Okay. Other things about the morphology, those two we'll talk about later on. Bilobed, there is a disorder known as Pelger-Hewitt anomaly. So you have what's called hypolobulation. So in other words, instead of having a bunch of little segs, you may have two, or you may just have one little tiny one. That's an indicator that they may have Pelger-Hewitt anomaly. Now later on we'll talk more about Pelger-Hewitt when we start getting into the white blood cell stuff. Okay. Hypersegmentation. So like normally a seg should be like 3 to 5. Hypersegmentation is like 7 to 12. Okay. Those guys, that's an indicator they're either going to be really, really large. This is an indicator of pernicious anemia, vitamin B12 folate deficiency. It's also known as megaloblastic anemia. Okay. And then you have pynotic or pycnotic, however you want to say it. I said it's probably actually pronounced, I've called it pycnotic my whole life, but it actually is probably pronounced pynotic. Pynotic cells. That's when that little nucleus looks like the meta. You know, we looked at the metarubicyte, and we talked about the nucleus begins to die. Sometimes neutrophil nuclei can do this. Those little segs will turn black, you know, okay? That's a sign that the cell is dying, okay? And then we talked about reactive lymphocytes, and I'm not going to talk about plasmacytoid cells yet. We'll talk about that later on, okay? So do be familiar with that chart. Go ahead and look at that chart sometime before next lecture, okay? As we go. All right? Questions about acanthocytes, guys? All right, codocytes. Codocytes are target cells. We already talked about this. Remember I told you guys, don't confuse target cells with macro target cells. Remember I talked about that when we were talking about the cholesterol and phospholipid ratio. When you have that increase, you see the macro codocytes. Okay, codocyte is a target cell. Now, if it's a large target cell, yes, then you could call it a macro target cell. But just know in general that codocytes are known as target cells. Okay, and I have showed you guys those. They look like a bullseye. Okay. They can be artifacts, but you do see an increase in these in what we call hemoglobinopathies. So people that have sickle cell, hemoglobin SC disease, hemoglobin C disease, any kind of hemoglobinopathy, you see an increase in target cells. Okay? These are target cells. You see those target cells, guys? Okay. I know why I don't have an acanthocyte picture in there. It's because we've already looked at an acanthocyte. When we were talking about those lipids and the cholesterol and phospholipids, I put acanthocytes on there. That's where I don't have just a separate picture. Okay, questions about codocytes? Okay, you are responsible for knowing target cell and codocyte. Okay, make sure you know the science term for them. Okay.
Are the target cells and codocytes the same?
Yes, it's just different names for them. Codocyte is the true name, is the scientific name. Target cell is what we call them when we're doing diffs and stuff. Because if you put codocyte, a doctor wouldn't know what you was talking about. Really and truly. I know that sounds ugly, but I promise you they wouldn't. Okay? All right? Dacryocytes, or dacrocytes, however you want to say it. It's actually, I think, pronounced dacryocyte. These are known as teardrop cells. Okay? These are formed sometimes because of the same thing, like as you're passing through the spleen, the macrophage tries to jerk something out of it, and it stretches out the cell, and it can't return because maybe it's older. and so it's stretched and can't return its shape. So you end up having what we call teardrop cells. Okay, this is a teardrop cell. Okay, teardrops, the cryocyte. All right, these are teardrops. You ought to be able to spot those. Right, look just like tears. Okay, this one right here would be classified as an acanthocyte. Let's see that cell right there. That's an acanthocyte, or a spur cell. Okay, got a little spur sticking out of it, right? So this is an acanthocyte. This is also they're calling this one an acanthocyte. Most people would probably call that a burr cell, but whatever, you know, I'm not going to argue with them. But to me, this is an acanthocyte. I might even call that an acanthocyte.
What about the one below the 3?
That?
No.
That? Nah, it's an artifact.
Oh.
It's kind of just a weird little thing, probably from making a slide.
So what is 2 if it's not a?
Most people would probably call that a burr cell. I mean, it's almost a spherocyte is what it looks like, but because see, it's missing its central pallor. And a lot of times acanthocytes will still have its almost part of its central pallor. You can see it's kind of a light area right there, even though it's stretched. You can kind of see a little bit of light in it. Okay, so that's an acanthocyte. All right, sickle cells. Sickle cells are known as drepanocytes. Drepanocytes. Sickle cells, you're never going to see a sickle cell unless it's a true hemoglobin S patient. So they have sickle cell anemia. Okay, and we'll talk about this later on. People who have sickle cell anemia have normal cells all the time until something happens and their oxygen level drops. Then they get sickle cells. Sickle cell crisis is what it's called. It's called a sickle cell crisis. Okay, but sometimes after having so many crises I guess it's crises plural. You say crises. Having multiple crises, I guess is what you would really say. Cells become irreversible. In other words, they can't bounce back from being sickled. And say you might still see sickle cells in just a sickle cell patient, even though they're not in crisis. Okay, but the majority of the time, once you get their oxygen level back up to what it needs to be, the cells will go right back to normal shape. Okay, as we go. All right. So just like we talked about, there's an abnormal hemoglobin. It polymerizes, which means basically it turns into a milkshake. Instead of being liquid form, it turns into a milkshake, gets thick, and so it causes the cell to basically draw in on itself. Okay, and so we didn't put a picture of a sickle cell. I can't believe I don't have a picture of a freaking sickle cell. I'll show you some pictures of sickle cells though. They're in your book. Okay.
There was something that had a sickle cell.
Yeah, earlier I did show you one. That one, it had that macrocodocyte on it. Earlier in your thing, there was a sickle cell right beside the codocyte, the macrocodocyte. Okay. Echinocytes, also known as burr cells. These are usually, it is reversible. They can revert back to the normal discocyte. Can become spherocytes though, depending on what's going on. Usually removed. Echino is the same as like starfish, sponges, urchins, those kind of things. So they're going to have those little spikes on them. That's what echino means, burr cells. Okay. Carmen artifact, especially due to the glass effect. In other words, the negative attraction of the glass itself can cause the cells to do that. And then usually if the blood has been refrigerated for several days and you try to make a slide on it, then you're going to see burr cells. And those are artifacts. Okay? These are echinocytes. Okay, so you definitely can see those. Got the spickles on them. They're burr cells. And if you live in Alabama, you know what a burr is. If you've ever went out in the woods, you get a cuckleburr on you, right? Got the little spiky things on the side. Oh, damn Yankee there, she might not know what a cuckleburr is, but everybody else living in Alabama knows what a cuckleburr is. Okay, so think about the spikes there. Okay, questions about that, guys? All right. elliptocytes. Okay, now listen to me. We're going to talk about two cells. We're going to talk about an elliptocyte, and we're going to talk about an ovallocyte. Okay? Most hospitals today count them as the same thing. An elliptocyte and an ovallocyte as being the same. But they're really not. Okay? Theoretically, they're not the same cell. Okay? Elliptocytes have elongated parallel sides. Okay? Whereas ovallocytes look like an oval. They look like an egg. Okay? And I'm going to show you. Okay? Also called pencil or cigar cells. All right? They're usually formed after cells leave the bone marrow as they're squeezing through those endothelial cell pores to get out into the bloodstream. But then they bounce back like they're supposed to, but sometimes they don't. Okay? Our spleen should get rid of them, but sometimes they don't. But there is a disorder, a genetic abnormality that's called hereditary elliptocytosis. When you see this, you're going to have elliptocytes, so the predominant shape of all the red cells. Okay? All right? So, elliptocytes have parallel sides. See them? How they're long and round like that? Okay? They're always going to have parallel sides. Whereas ovallocytes don't. Okay? All right? So they're kind of oval shaped. See, like an egg. Right? So they look just like an egg. Ovallocytes do. But listen, when you get into the, not that one, I shouldn't have said that one. This one is an ovallocyte. This one's got an oval shape too. But when you get into the hospital, when you're doing your clinicals, and you're doing a diff or a morphology, techs are going to call elliptocytes and ovallocytes interchangeably. Okay? But in theory, and you need to know this for your boards, they're not the same. It's two different cells. Does that make sense? Okay? So elliptocytes have two parallel sides, look like a pencil or a cigar, and ovallocytes look like eggs. And they're totally different, shape-wise. Okay? But I'm just telling you, when you get into the hospital, elliptocytes and ovallocytes are interchangeable terms. And they really shouldn't be, but they are. Okay? Questions about that? All right. Keratocytes or helmet cells. Keratocytes or helmet cells. And most people call these helmet cells, is what they refer to them as. Okay? And this, we've talked about this before. It's produced by impalement on a fibrin strand. Can be that. Kind of gives them little horn-looking things, or they look like the old-timey helmets that you have. Okay? And we have seen those, talked about those. They sometimes can produce a vacuole-like inclusion. And if you see these are called blister cells when they have this. Okay? Have a little vacuole-like inclusion. And then one side of it can burst, and that's what gives you the two spicules a lot of times. Okay? So you can see this two right here are blister cells. These would be considered blister cells. And then these would be your helmet cells. Okay? Keratocytes. But like I said, we call them helmet cells most of the time. All right, questions about those? Mesocytes. Okay? Mesocytes. Cells with more than two concavities. Most have a dark staining band across the center. Surrounded by a rim of ink, pink staining hemoglobin. We don't know what causes them. We just know, like, like when you were a kid and you kind of pushed your knee skin up, that's what a mesocyte is. And unfortunately, meso means inside, and that's why it's called that. Okay? Mesocyte. That's what it looks like. It's like you've literally pinched the middle to have a protrusion in the middle of it. They're known as mesocytes. Okay? Mesocytes. Don't get mesocytes and stomatocytes mixed up. Okay? Stomatocytes, you're going to have the clearing in the middle, okay? Whereas nesocytes, the center is going to be pink. It's going to be because it's like been squeezed together. Does that make sense? Okay. All right. Nesocytes. Questions about nesocytes? All right. Leptocytes. Lepto. Thin, flat cells with normal or larger than normal diameter. MCV is usually decreased in these. Hemoglobin usually cup-shaped like a stomatocyte. Target cells can be formed from leptocytes on dried blood smears. Okay. Leptocytes. Okay. And you can see how they got that kind of large looking area. Okay. Lepto. Okay. Listen, I never heard of a leptocyte until I started teaching this class. So you're not going to see many leptocytes. Nobody wants you to know what a leptocyte is, okay? But you do need to know that there is such a thing, okay? Schistocytes. So these are actually what I was talking about a while ago. A canthocyte is different than a schistocyte. Schistocytes are actually RBC fragments, all right? So these are like pieces of red blood cell that have been left. Usually they are microcytic, very, very small. It's just normal deformability, but reduced survival. Okay, so in other words, they can kind of do what they need to do. They just don't survive the whole 120 days most of the time. Okay, and this is usually caused by mechanical damage to the cells. It could be from making a slide. It could be from going through certain capillaries that are too small, those kind of things. All right. Fragments can assume a spherical shape and may hemolyze or be removed by the spleen. So like those are fragments. So like that one would be a fragment, that's a fragment, that would be considered a fragment. You know, shoot, I'd probably call that a fragment, me personally, if I was doing a bit up here. Okay. Those are all fragments. Okay, schistocytes. See a lot of schistocytes in burn patients for some reason because they've lost that outer skin covering, and so like they're prone to like dehydration and those kind of things, and so it affects the shapes of their red cells. Okay. All right, spherocyte. We've talked about spherocytes already, so this one's not a new one to you guys, but here is some writing about the spherocytes and where they come from and why they happen. And number 4 is the spherocyte. Notice how much darker it is compared to the rest of them because it has that hyperchromia, right? So it has more hemoglobin than the size of the cell. So it's being pushed out and doesn't have that biconcave shape. This one and this one would be considered spherocytes. Number 4, and then of course this little long guy up here would also be a spherocyte, okay? Questions about a spherocyte? We've talked a lot about it, so it shouldn't be a problem with you guys. Okay. All right, stomatocytes or mouth cells. You also put on here slot cells. Sometimes people call them slot cells. This looks like the slot where you put coins and stuff. We talked about this. This is caused by extra cholesterol in the leaves, the inner leaf, I believe it was. And so, yeah, the inner leaflet gets kind of fat cholesterol stuck in between the 2 phosphoheads, kind of pushes it out, and that gives us that stomatocyte look. Okay, can appear as artifact on smear, so you need to make sure when you're calling them that it is true stomatocytes and not some kind of an artifact. Okay, in other words, if you see 1 per 100 white red cells, it's not really true stomatocytes. It's probably an artifact. If you see 10, you know, 1 every other field, you know, then it's probably something that is significant. Okay. All right. And so these would be stomatocytes here, 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 and here. Okay. I tried to give them the weight on you and they wouldn't do it, Kara. Nothing. I'm just aggravating you. All right. Variation. I'm sorry. Huh?
You know what a cockleberry is?
You know what a cockleberry is? Uh-huh. Cockleburr.
No.
Yeah, see, I told you, damn Yankee wouldn't know. You ever been in the woods around your house or in a field around your house where you live and you get those big brown, look like egg things that's got stickies? Yes, those are called cuckleburs in Alabama.
Sticky something. Sticky something.
Well, they're called cuckleburs in Alabama. So, but anyway, so we have burr cells. They're called echinocytes too. We were talking about, and they have little stickies on them. Okay, good. All right. So variations in hemoglobin. So color is a big thing. So we've already talked about color. So we know we have hypochromia and hyperchromia. So normal RBCs, we talked about that central pallor being about 1/3 of the diameter of the RBC. We've already mentioned hyperchromia. We don't use that term because then we just call it spherocytes, okay? But we do use hypochromia, all right? Hypochromia is when there's greater than 1/3 of the central pallor. So we're looking at washed out cells. That's a term you're going to hear a lot me say. And I just say it because I'm old, you know, and old school. But when you get into clinicals, guess who's going to be taking care of you and helping you with your classes? Old techs like me, okay? So they may not use the word hypochromia. They may say the cells are washed out, okay? Washed out means hypochromia. It means their central pallor is a lot larger than they should be. They don't have the hemoglobin like they should, okay? So hypochromia equals decreased MCHC, okay? This is hypochromia by far, okay? This patient probably, looking at the size of the cells and that kind of thing, they may have like thalassemia or something, okay? We'll talk about thalassemia later on. But these cells are hypochromic. See how washed out they look, especially like this one. See, it doesn't have hardly any hemoglobin in it, okay? So this is a big concern for anemic patients, all right? A lot of these are microcytes, so maybe iron deficient too. You know, I just don't know what the deal is. Yeah, saying some of them, most of them are normocytic, so should be good. So it could be some kind of a weird thalassemia or something that they got the blood from, okay? All right, another color that you need to be familiar with, the term is polychromatophilic. Okay, we've already talked about that. That's that blue color. When the cells appear bluish and large, 9 times out of 10 it is reticulocytes. Okay, and they are known as polychromasia or polychromatophilic. Okay, bluish tinge. All right, questions about that? Okay. This is a little chart that kind of tells you about those as you need them. All right, so let's talk about some inclusions now. Inclusions are things that are inside the red cell that shouldn't be there. There should never be anything inside the red cell that you can see, okay, on a right stain. All right, so them having their presence can help you determine what's going on. All right, basophilic stippling, okay. I always look at these. Y'all remember them little speckled eggs you used to get when you were a kid at Easter? You know, I'm talking about had little robin eggs, but they had like speckles on them, okay? That's what basophilic stippling looks like. It's little speckles inside the red blood cell, okay? The thing about it, though, is basophilic stippling, that cell is dead. It is a dead cell. It can't do any kind of respiration anymore. Okay, not even anaerobic, so it is a dead cell. All right, you see an increase in basophilic stippling in lead poisoning. Okay, anybody know what the true term for lead poisoning or the scientific term for lead poisoning is? What's lead's symbol on the periodic table? L-E. N-O. No. It is P-B. Did y'all know that? Lead is P-B. You think, well, how in the crap does L-P-B for lead? Well, where did most of our symbols come from on the periodic table? What language of science do we use? It's a dead language. Latin. That's exactly right. The definition for lead poisoning is plumbism. Plumbism. Okay? Why do you call your plumber the plumber? Is he plumbing something? No. Pipes used to be made out of what? Lead. All plumbing pipes used to be made out of lead years ago. It's probably the reason most people were crazy back in the day. All them crazy kings, right? Because they're the only ones that had plumbing, you know. It's lead poisoning as you go. Okay? So basophilic stippling can be an indicator of lead poisoning, all right? It can also be an artifact because, like we talked about, it's just a dead cell, all right? So here's the word lead poisoning. It can also be associated with some anemias and abnormal hemoglobin synthesis and thalassemia. We'll talk about thalassemias later on, okay? This is what basophilic stippling looks like. You see those cells, they're speckled. That's very common in people who have lead poisoning. Okay, questions about basophilic stippling? Okay.
Well, why is it there?
Because those cells are just dead. They're just in your, I mean, they just hadn't made it to the spleen yet.
Oh, okay.
Yeah, most likely. Remember, when you draw blood, you're getting like a picture, a moment in time of your blood circulation when you draw that blood. So, you know, you may draw the second tube and not see any, you know, just depends. Okay. Cabot rings. Cabot rings. These are usually little reddish violet inclusions. Sometimes they have a figure 8 shape. They can also be oval rings. They're basically remnants of the spindle fibers. So you guys remember mitosis? Remember we talked about PMAT the other day? Made mention of that. You know, you got your cells, one in metaphase. Cells are lining up on the equator, the genes, the chromosomes, okay? And then the next phase, anaphase, you start getting the split chromosomes, right? And then in telophase, you get some division, starts looking like that, right? And then you've got your chromosomes starting to spread back out, those kind of things. Well, what makes the chromosomes go from here to here? That's right. They're called spindle fibers. Remember the centromere in the cell? There's actually little spindle fibers that attach to the chromosomes. And then they pull them over, and then they shorten as they pull the stuff over. So what the theory is Cabot rings are remnants of those spindle fibers that was left over from mitosis when that cell was going through mitotic divisions in the bone marrow. Okay?
So how did it turn into like a figure 8?
It just kind of gets tossed around inside the cell just from the movement and those kind of things. Let's see, if I put a bunch of wire or something, say wire, in a big bag and then started shaking the bag, it's going to like change the weirdness of it, right? And then you could open it up and look at it and you might see shapes in it. Okay? You got to remember that cell going through mitosis and then the process of going through the those endothelial cells to get into the bloodstream, the peripheral blood, and then just being bounced against the vessels and everything else that's inside. So I'm sure it's just a chance. It doesn't always have to be a figure 8, but the figure 8 shape does give it away. Okay? And that's what it looks like.
What's that on the left side of it?
Another cell? Oh, what you talking about?
Yeah.
You mean the left side of it?
That.
Oh, that little dot?
No.
Or that?
That.
That's just a screwed up cell. Still red cell.
Is the dot significant?
Well, I wondered though if that's not like the centromere. Like remnants of the centromere. I don't know that for a fact. It may just be something in the stain. Could be a stain precipitate. but, you know, it would make sense that it still have part of that centromere left that controls the spindles. Okay?
This is abnormal.
Abnormal, yes, yes. They are inclusions. There is abnormal. Usually you see them in like anemias or anything that's causing increased erythropoiesis is usually one of the things that you see.
What's dyserythropoiesis?
Huh?
I don't know how to say this word.
Erythropoiesis?
No.
Oh, dyserythropoiesis. Dys means abnormal. Anytime you see dys in front of something, that's a prefix that means abnormal. So dyserythropoiesis means abnormal erythropoiesis. Okay, so like maybe it doesn't complete, you know, how we talked about, you know, the ruboblast divides, goes through several phases of mitosis. Okay, something happens and it stops and doesn't continue. Okay, that would be dyserythropoiesis. There was an abnormality in the production. Okay, all right. Questions about Cabot rings, guys? Okay. Red cell inclusions continued. Hal Jolly bodies. These are very common. You can see these. Hal Jolly bodies are basically remnants of the nucleus. Okay. So if I ask you the composition, you would tell me DNA. Okay. Hal Jolly bodies are remnants of the nucleus. So their composition is DNA. All right. Usually occur in RBCs, rarely more than 2 per cell. Usually you just see 1 in that. This is, well, staining also, but sometimes Heinz bodies can actually look like Hal Jolly bodies. But you got to remember, Hal Jolly bodies we can see on right stain. Heinz bodies you have to see on supravital stain. So you'd have to use like new methylene blue or brilliant crystal blue, something else. Okay?
What stain is for this one?
Huh?
What stain is this one?
Right stain. Yeah, you would see this on a normal right stain. Okay? You can see these in people that have a splenectomy, how you say that? Splenectomy, there you go. So yeah, we probably could see some in yours. Also in megablastic anemia, some hemolytic anemias, and then functional asplenemia and severe anemias. This is what Hal Jolly bodies look like. Okay, you will be familiar with this. You will see these a lot. It's pretty common to see Hal Jolly bodies. Okay, questions? What time is it? Okay, give me just another minute, and then we'll see what we got. All right, Heinz bodies we've already talked about. Remember, Heinz bodies have to be used with a supravital stain. It is aggregated, denatured hemoglobin. The hemoglobin is oxidized and become denatured, so its shape has changed. Y'all know that, right? What denature means? Y'all heard that term in chemistry? All right, so how many of you cook? All right, so everybody that cooks has cooked an egg sometime in their life, right? So you crack an egg, put it in there. When it comes into the pan, it's like a clear jelly looking, the white part is. But then what happens to the white part, or that jelly part? It gets thicker and becomes white, like bright white, right? The jelly is albumin. It's a protein, okay? That protein, because of the heat, changes its structure. And so it's still albumin. Because you changed its structure, you denatured it, okay? So when we talk about denaturing hemoglobin, later on I'm going to show you pictures of hemoglobin in the next chapter. It just means that they get changed. The shapes get changed. And so they precipitate or change looks. And so they pick up certain stains that they normally wouldn't pick up, okay, as that. All right. Seen in G6PD deficiency, that's one of the things you need to know for sure. Heinz bodies, G6PD deficiency need to go hand in hand, okay? This is what they look like on a supravital stain. Exactly, and there would be two different stains too, so you would never get them confused, okay? Because you're never going to see Heinz bodies on a right stain. You have to use a supervital stain, so like New Methylene Blue, Brilliant Crescel Blue, those kind of things, okay? Does that make sense? All right. Hal Jolly bodies, though, you can see all the time. All right, so here is a little chart, table 1010 in your book that goes over them. The only one we didn't talk about is those Pappenheimer bodies. Okay, there's that term Pappenheimer that we mentioned earlier. Pappenheimer is iron aggregates in right stain. If you're looking at a right stain and you see these little pieces of iron in it, then they are known as Pappenheimer bodies. Okay. All right. But then if we use Pearl's Prussian Blue, then they are known as siderotic granules. Okay, and then the cell names change. All right. We've talked about sideroblast and siderocytes already. This is what iron stain looks like, though. I don't think I've put you a picture up there. This is an iron stain of a bone marrow. Okay, so these would be sideroblast. We'd call these sideroblast because they're nucleated. Okay, but you can see that blue iron in it. Every erythrocyte should have some iron in it, right? That's a sideroblast in the bone marrow. If you don't, you know you're not getting erythropoietin production like you should. Okay, you don't have enough iron, so you're going to see a decrease in the cells. This is a siderocyte. Okay, this is Pappenheimer bodies, and then this is Pearl's Prussian Blue, and you can see the difference in the colors. Okay. All right. I think that's about all we need to talk about right there, guys. We just talked about them. That's the pictures of them. You guys can look at this. Let me mention this real quick, and then we'll be done. Delta checks. Okay, delta checks are a check system for us in the lab. So let's say that Kara is working in hematology. She gets a patient come in. They come in through the ER. Their CBC. Their hemoglobin was 8. Hematocrit was what? What should their hematocrit be if their hemoglobin is 8?
24.
24 plus or minus 3, right? So let's say it's 25. Okay? So that fits in our rule of 3, right? So it's good. So we're going to release it, everything else. Okay? 2 hours later, you get another tube that has the same patient's name on it, and their hemoglobin's 15. Right? Well, your computer is going to go beep, 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 and it's going to say delta check, delta check, delta check. So what should Kara do? First of all, Kara should say, hey, blood bank, did y'all give Miss Brown 4 units of blood? You know? Because that's probably what it would take to make it from 8 to 15. You know what I mean? And they say, oh yeah, we gave her some blood. She was an active GI bleed. So Kara say, gave patient blood, good to go. Right? Okay? Blood bank says, hey, no, we don't have nothing on that patient. You know, because some doctors don't do blood transfusions until their hemoglobin gets 6 or 7. Okay? So they may not do anything. But yet 2 hours later, her hemoglobin's 15. So what should Kara do? Well, when in doubt, what do?
Good.
Y'all don't know yet, do you? When in doubt, we do it again. And what do to do it again? We call the phlebotomist and say, hey, dumbass, go get this recollected because you stuck the wrong patient. Right?
Right.
So, you don't have to be that mean. Don't be that
Oh,
mean.
I can't.
It's just mean. You would get it recollected. But how would you have known that if you didn't have a delta check? Every hospital system has a delta check. It may not call it delta check, but that's what it is. It's a verification process to make sure it hasn't changed. Now, delta checks can be a pain sometimes because they're set for like a week, you know? Lots of things can change in a week in a patient, really and truly, okay? So you have to kind of look at your delta checks and say, well, it's been 7 days. We don't know the history or whatever. So just let it go, okay? But when it's just a day or so and you know that you haven't done any kind of intervention, then you need to really look at those delta checks and make sure that you're doing the right thing. Okay?
So, what's like an example of?
I just gave you an example. But I'll be glad to give you another one if you want me to. I mean, I really will. I don't mind at all. Okay? So post-examination basically is just dealing with your list system, getting that report to the doctor, and making sure it's done in a right way. Okay? So you can kind of read through that stuff. Variations in the CBC is just like we talked about in the last chapter of the kinetics of the blood. Newborns are going to be different. Adults, females, adult males are all going to have different ranges, and you got to be familiar with that. Okay? Because think about a WBC on a newborn. WBC count on a newborn is normal is like 10 to 30,000. Okay? Whereas if we get an adult that's got a 30,000 white count, we've got a problem. Either they have a really bad infection or they're going toward a leukemia. Okay? Does that make sense? So that's important to know, is the variations in those normal ranges. Okay? And I think that's it. Okay? And we've talked about all this in the past. All right? All right, my guys.